Hi, everyone. Thank you for joining us today for the African Global Mental Health Institute Collaborative Clinical Education webinar. I'm Dr. Michelle Durham. I'm a child psychiatrist and co-chair for the Training and Education pillar of AGMHI. I'm joined today with Anusha Lachman, who is also a co-chair for the Clinical Training pillar of AGMHI. For those of us who are new to this webinar series in general, each of the clinical care delivery and the training and education have done webinars historically over the past year separately, but today we're trying to do something new and have a joint webinar presentation. Also, for those new, I want to describe a little bit about the African Global Mental Health Institute, which we support the advancement of mental health care in Africa and the diaspora across 4 domains of research, training, and education: clinical care delivery, and advocacy and policy. The HMHI equips mental health professionals in Africa and the diaspora with the tools and agency to effectively care for those suffering from mental illness. We foster collaborations, create accessible training and education programs for both providers and the public, conduct and disseminate culturally relevant research, and partner with key advocacy and policy leaders to advance mental health care in Africa. I hope that for those of you who are new to the webinar, thanks so much for joining today. Go to agmhi.org where you'll see more about membership, past webinars, and also see how you can get access to the resources that we have, as well as thinking about coming to our next conference, which will be in Durban, South Africa, later in 2025. Today, I'm joined by 2 stellar individuals. We're going to be talking about substance use disorders, inequities in access and treatment in Africa and the diaspora, a topic that is near and dear, I hope, to many of us on the call today, but for those that it isn't, that we also think about as mental health professionals or folks that are treating individuals with mental health needs, that substance use does play a role and misuse plays a role in many people's lives. Dr. Oluwole Jegede is an assistant professor of psychiatry at Yale University School of Medicine, medical director of the Mobile Crisis Intervention Services and Medication for Addiction Treatment, the MAT Clinic at Connecticut Mental Health Center in New Haven, Connecticut. He obtained his medical degree from the University of Ibadan, Nigeria, before proceeding to the US for residency training. His interest is in the field of addictions with focus on health disparities and mental health outcomes research, particularly in underserved populations. His work explores how structural vulnerabilities, systemic inequalities affect access to and the quality of mental health and addiction care. He's on the physician scientist track at Yale University School of Medicine, and his research examines complex interactions between substance use disorders, psychiatric care, particularly in populations that experience higher rates of health disparities. Dr. Abdul Jalloh is a lecturer at the College of Medicine and Allied Health Sciences at the University of Sierra Leone, a consulting psychiatrist at the Sierra Leone Psychiatric Teaching Hospital in Freetown, and an honorary clinical lecturer at the School of Health and Wellbeing at the University of Glasgow, United Kingdom. He's played a pivotal role in transforming the mental health landscape in Sierra Leone through his leadership at the psychiatric hospital. He has addressed critical issues related to resources and infrastructure, recognizing the urgent need to tackle substance use and child mental health. He successfully advocated for the establishment of Sierra Leone's first drug treatment and rehabilitation center, as well as child and adolescent mental health unit. He is committed to advancing global mental health, and his focus has been on addiction and the effects of psychoactive substance use in general. So with that, I'd love to start the webinar today with thinking a little bit about just providing a clinical picture for all of us, especially maybe for those of us that aren't seeing that many folks with substance use. And so Dr. Jegede will provide a short clinical case, a discussion sort of highlighting the complexities that we see with medical addiction treatment services within a public health setting. So I'll let you take it, Dr. Jegede.
Thank you, Dr. Durham. It's very I'm happy to be here. It's a sort of a very interesting 360, if you will. I've always wanted to do something for, with Africa and Africans since I left, and I'm just glad that we're doing this today. Thank you to AGMHI. So I'm going to present a case which basically discusses my clinical work and the sort of patients that I see at the Medication for Addiction Treatment Clinic. So just a brief about the clinic. The MAT is a clinic is a consultation model program. It's an innovative model care that follows the consultation model in the ambulatory setting. So typically when we hear about consultation clinics or consultation programs, we think about the inpatient service in the hospital, in the hospitals in general. But this is basically an outpatient consultation service that provide clinical consultation and clinical related issues to staff, community, patients, and also provide treatment for patients with substance use disorders. This clinic was started by Anna Jordan in 2020, and I started to run the clinic since 2021. So we present a case of somebody I would call Peter. This is not an actual case, but a composite of cases that I typically see in my practice. And if you have any questions, just post it in the discussion box. So Mr. Peter is a 63-year-old undocumented African immigrant, Yoruba speaking only, who currently resides in a supportive housing after several years of street homelessness. Mr. Peter is currently being followed by the ACT team. ACT team is the Assertive Community Treatment Team, and I'll talk about that in a minute, of the Community Mental Health Center. He was referred to the Ambulatory Addiction Medicine Service for the management of severe alcohol use disorder and cocaine use disorder. Mr. Peter has had multiple hospitalizations related to his history of falls. He's had 3 previous opioid overdoses. He has a psychiatric diagnosis of schizoaffective disorder, bipolar type, generalized anxiety disorder, and other several medical complications and diagnosis, including HIV, hypertension, type 2 diabetes, traumatic brain injury, diverticulitis, mild cognitive impairment, latent lung tuberculosis, closed fracture of the ribs and clavicle, and peripheral neuropathy. He has no history of suicidal or homicidal ideations, plans, or intent. As far as his substance use history, he started drinking at the age of 13, but his drinking escalated 10 years ago when he moved to the United States. He has a history of complicated withdrawals, drinks about 2 pints of vodka every day, multiple intoxication episodes. He's had several withdrawal treatments or detoxifications in the hospital, and panhandles to support his use. For cocaine, he started smoking crack cocaine in his 50s, smokes about $40 every day, and smokes about 1 pack of cigarettes a day. In clinic today, he comes in from the hospital emergency room, where he was taken by ambulance earlier that day. At the emergency room, he wasn't able to provide any coherent history due to being intoxicated, but reported that he thought he might have fallen in his bathroom earlier that morning. He was held overnight and discharged in the morning. When he came to clinic, his vitals were stable. However, on physical exam, he was chronically ill-looking, smelled of alcohol, and had difficulty ambulating. His urine toxicology screen was positive for cocaine and fentanyl, even though he endorsed smoking only crack cocaine. His urine was positive for fentanyl, which is a highly potent synthetic opioid. He has not been adhering with his medications because he also has challenges with the pill organizer because, he has a peripheral neuropathy. He's unable to organize his medications himself at home. Next, I will just discuss the complexities of this case, including the healthcare system as a determinant of health, the role of social determinants and approaches to care in a typically highly evolved American public health system, which is where I work. That is the Community Mental Health Center. So this case highlights the complexity of addiction treatment in a public health setting in the United States. Some of the issues I see, which we would also discuss, and I'll open this up very shortly, and Dr. Abdul Jalloh will also provide the African perspective. So we have here challenges with occurring disorders. We have here somebody with a severe substance use disorder, severe mental illness, and several medical comorbidities. From a psychopathological and social perspective, this makes the case very challenging. So challenging that I provide every month co-occurring disorder consultations in the state of Connecticut to a group of clinicians. We pick out people with severe co-occurring disorders and we discuss the case every month. This is how important we think co-occurring disorders are. His medical complications interact and complicate management, especially with medication adherence issues. His history of falls, including rib and clavicular fractures, complicates his balance problems and the peripheral neuropathy, and also may exacerbate the altered mental status and traumatic brain injury. This man has a history of complicated withdrawals, which of course poses another layer of risk to him, the delirium tremens, seizures, and ongoing liver damage. Another thing I find very poignant about this case is the fact that his urine toxicology was positive for fentanyl, even though he was not, it did not report using opioids. That raises concern for an unintentional opioid exposure, which is potentially lethal, requiring opioid overdose prevention strategies. Further, I told you that he was an undocumented immigrant, so his status limits his access to healthcare services, insurance coverage, and social support networks. He also does not speak very good English. He speaks only Yoruba, which I happen to speak, but this exclusively speaking Yoruba complicates his communication, necessitating language services for effective care. We may have to use language lines, and it's even more challenging in a state like Connecticut to find a Yoruba speaker, unlike, say, bigger cities like Boston or New York. He has been chronically homeless, but interestingly, now he has supportive housing, which suggests some stabilization, but ongoing housing insecurity and poverty continues to remain critical issues. Like I told you, he panhandles for substances, which shows that he has limited financial resources, and then limiting his access to basic needs and healthcare. I discussed the challenge of highly potent synthetic opioids like fentanyl and fentanyl analogs in the community and his unintentional exposure, which evidently increases his risk for overdose. He has had 3 previous overdoses in the past and continues to be constantly exposed. What I see in my clinic is people who don't necessarily have opioid use disorder, who have been stable using whatever drugs they were using for all those many years ago. Now we're seeing people who are unfortunately overdosing and many times also joining the mortality numbers. And we are currently in the 4th phase of the opioid epidemic. Unfortunately, this continues to be an ongoing issue. Also, we also see here that even when access to care is constant, in this person who has access to the MET clinic, has access to services, he continues to have poor health outcomes. And this has been backed up with research. Why is it that people with who may even have ostensibly access to care continue to have poor mental health outcomes? I'll talk about the strengths of my setting as a well-resourced service environment. The CMHC caters to people specifically who are underserved, and most of them, of course, have Medicaid, which is the state medical insurance. I have my interdisciplinary collaboration with the ACT team, assertive community treatment, which consists of psychiatrists, nurses, case managers, clinical social workers, peer specialists, and these people really bring treatment to the community, bring treatment to the patients where they live. I have the good fortune of working with these kinds of people, these kinds of teams, the ACT team, and also the mobile crisis and intervention, which responds to community needs, people experiencing crisis, trauma-related crisis, substance use-related crisis, with the goal of providing comprehensive and efficient evaluation. Furthermore, I also have the good fortune of working with my team here at the CMHC, which is able to provide medications to this patient who obviously doesn't have insurance because of the immigration status and is unable to pay. Also, provision of supportive housing. So that is the quick synopsis of my case. Hopefully, we have a good discussion. Thank you very much.
Thank you, Dr. Jegede, for that case, a very complex case with lots of different things going on that I'm sure we could all keep talking about. I want, before we start asking questions, Dr. Lachman and I, for folks in the audience, if you have anything you wanted to clarify or a question about anything, please put it in the Q&A. This can be very as much interactive as possible, so please put in the Q&A. Before we move on, though, I'd love for Dr. Jalloh to sort of comment on this clinical case presentation, and really from the perspective of what happens in the African context, what seems similar to folks you see, maybe what seems different, and if you can elaborate on any of those particular issues that Dr. Jegede brought up as well. Dr. Jalloh, can you hear us okay?
Yes. Good afternoon from Sierra Leone. Thank you so much for this opportunity. And I've been looking forward to this opportunity to showcase what we are doing in Africa, per se, in terms of substance use disorders. The case that Dr. Oluwole present, I think it's similar to what we normally see in our clinical settings, and wherein we have co-occurring psychiatric disorders with medical conditions, and also the issue of medication adherence, the issue of overdose also is very common in our settings. So, in fact, I saw a case quite recently, a young guy who had similar clinical diagnosis. For us, cocaine is common. It's not that common, but the thing that is very common in Sierra Leone is tramadol, and then a psychoactive substance called kush. Kush is a cocktail, is a mixture of different psychoactive substances. It contains amphetamine, it contains marijuana, and sometimes tramadol. So it's a concoction of different psychoactive substances. So basically, most addicts overdose with these psychoactive substance, and they present with life-threatening signs and symptoms. So sometimes they present with physical clinical manifestations. Sometimes they present with wounds, which looks like gangrene, and swollen abdomen, swollen faces, and weight loss, malnourishment, with infectious diseases like HIV, hepatitis. So they are very common diagnosis or clinical manifestations we see in patients that normally abuse opioid, tramadol, and kush. In fact, we have like two types of kush. We have the one that is tramadol based and the one that is non-tramadol based. So with the one with the tramadol, it makes them sleep a lot. They sleep a lot. Some sleep a lot, whereas others, it makes them become more active to walk. So one who uses tramadol can walk throughout the day without resting. So they use this psychoactive substance, the kush, sometimes for them to be very active, and then others use it to sleep. Some can sleep for the rest of the day. From morning to night, they can sleep when they take the kush. So the clinical manifestations may be different in terms of how they present here. some of them they present like zombies. Yeah, which is I know it's also common in the US. The other difference is the physical signs and symptoms they present with swollen limbs, malnourishment, and some also can even present with organ failure. We have cases wherein people present with kidney damage, liver damage, and some even resulted in death. So the issue of push is something that is very serious in this part of the world. They also use different types of psychoactive substances, different types. And then they have different names they give to these psychoactive substances. For example, for ecstasy, they call it joy, because it makes them feel euphoric, top of the world. So they name it joy. There are so many new psychoactive substances in this part of the world. For the different, again, I think for the US, they have a well-established system in place, whereas in Sierra Leone or most part of Africa, we have issues with infrastructure. We have issues with medication, because currently in Sierra Leone, we don't have methadone, and it's just recently we are trying to implement naloxone, but there is a big challenge in terms of psychotropic medications, especially to counter the effects of opioid overdose. Again, we have issues with human resource. It's a big challenge in Sierra Leone or in most African countries. The mental health professionals, we are very few. For instance, in Sierra Leone, the second psychiatrist, the first one died a year ago, and then even the mental health professionals, the mental health nurses, they are very few. In total, have like 34 mental health nurses. We don't have any clinical psychologist. The one that we have is on contract, and she's a foreigner based at the psych hospital. We don't have occupational therapist. We don't addiction specialist. It's recently that ECOWAS is helping us to train addiction professionals, and in fact, they are not yet certified. They need to take the ICAP exam for them to become certified addiction professionals. We have issue with infrastructure. In fact, the mental health services currently in Sierra Leone is centralized in Freetown, and I'm sure that is what happens in most African countries. For example, in Liberia, I know they too, their mental health services is basically centralized in Monrovia, and Gambia also, most of their services is centralized in Banjul. And in Banjul, in fact, they have no psychiatrist currently. They only have one who is currently undergoing training in Ghana. So this issue of human resource is across most resource constrained settings in Africa. We also have issues with aftercare. Dr. Oluwole talks about housing and social support in the US. For us, that is severely lacking in this part of the world. We all know people with psychoactives, with addiction issues. They have been discriminated and stigmatized, and most of them are homeless. They sleep in the streets, and also these are the people that are mostly involved in crimes. So majority of them are in prison. So that is why in April 2024, the president declared drug and substance abuse as an emergency, as a public health emergency, so that we can be able to address this issue. So I think the scenario Dr. Oluwole presented is very similar. The only different is the services that are available in the US, which are lacking in this part of the world. It's very complex, but we are doing our best. Thank you.
Thank you, Dr. Jalloh. And Dr. Oluwole, I want to maybe just tie it together, which, you know, we often think that it is just about the resource. And obviously we can't compare the lack of resource or the inequities that we're talking about today in terms of what's available in the US versus Africa. And even Africa itself is distinctly divided in terms of areas of extreme availability of things. And we might be in sub-Saharan Africa thinking we don't have enough, but relative to, like Dr. Jalloh has just explained, you know, we seem quite privileged in that space. But I want to tie it together because despite there being that stark difference of resources, even in a space, Dr. Oluwole, you said, despite there being access and availability of services, I think it might be helpful for us to maybe unpack a little bit about what is it that makes it harder for people with substance use disorders, as well as coexisting complexities of mental illness and physical health difficulties that make it difficult for them to access the care. Because it appears that the resource is there. There is a community outreach, there is a facility that's available, there are allied team members that can come to the forefront of it. And yet there still is something that makes it inordinately difficult for people, particularly with this dual diagnosis or often triple diagnosis of a substance use disorder, a severe mental illness, and then, of course, the physical health complaint like HIV or one of the chronic illnesses. I wonder, Dr. Oluwole, if you just wanted to briefly give us a sense of that, because there is this that ties it together regardless of where you're placed.
Thank you, Dr. Blackman. This has been one of the thrusts of my work, is really thinking about inequities, particularly in underserved communities. Like you rightly said, even when access is constant, there still seem to be that certain individuals, certain populations still continue to suffer.
I'm tired. It was a long day.
Yeah,
Long day of seeing patients the whole day.
Sorry, we'll
another patient.
unmute everyone.
Okay.
Sorry, go ahead.
Yeah, thank you. So this still is the case, and research is actually convergent on this. If you think about, say, buprenorphine, for example, we know for a fact that African Americans don't get prescribed as much as other populations. And when they're prescribed, they prescribe less. In fact, there's a research by pretty recent research, 180 days from a sentinel event like an overdose, before and after, African Americans tend to get fewer prescriptions, you know, before and after, but not just buprenorphine, but also even with naloxone, which is the antidote for, overdose. African Americans also get less. So why is that? To my mind, I think it boils down to the structural inequities in healthcare system here. It's just the structure of the way our healthcare system is built with racism, to be honest with you, and not just racism at the structural level, but also at the individual level and also at the provider level. Someone, for example, like this case that I presented, who has been homeless at some point, a homeless person comes, we don't want to offer them services even. They go to the emergency room every time because they don't have primary care. We just see that they become a strain on the healthcare system and they regard it as frequent flyers. Even when they have a legitimate problem, they come to the hospital, in the emergency room, they don't get as much services as they should. Okay, and even if we let's think back about what happened with the opioid crisis. The opioid crisis actually started, the bedrock of which was inequities African Americans don't get diagnosed with pain or offered pain medications as much as other populations, which was when the first wave of the opioid crisis started in the white communities, and then now what we're seeing is the opioid crisis has really escalated in the African American communities and the Native American communities. So to answer your question and tie it together, I think it's based really on structural inequity, structural racism of our healthcare system. And some of my work right now is looking at the healthcare system as a social determinant of health in and of itself.
Great, thank you. I'm just wondering if there are no questions in the Q&A at the moment that I can see, or in the discussion, if we could maybe then move on. Perhaps Dr. Jalloh, you are going to give us an overview and a sense of the research that you're conducting in this space and from an African perspective. You go ahead.
Yeah, thank you so much. And I think I'm going to this opportunity to highlight what we are doing in Africa in general, locally, regionally, and continentally. I'm part of a network of epidemiologists collecting data on psychoactive substance use in Africa, from ECOWAS up to the Africa Union. So every year or every 6 months, we collect data looking at the types of psychoactive substance, frequency, looking at both demand and supply. Yeah. So I'm in charge of the demand reduction, and the law enforcement agency is in charge of the supply reduction. So for the demand reduction, we look at the types of psychoactive substance, the frequency, the age of onset, so many parameters. So across all African nations, we see that there is an exponential rise, especially in terms of new psychoactive substance, just like I mentioned earlier, like the Kush. Kush is more prominent in Sierra Leone, but it's now showing in the sub-region like Guinea, Liberia, and the Gambia. Kush is almost taking over all these countries. So we see that, again, for West Africa, it's like a transit point for psychoactive substance. So we see huge patients who are abusing these substances, and as a result of that, Sierra Leone and Liberia declare drug and substance use as a public health emergency last year. So as part of the declaration, the president of Sierra Leone tasked the Ministry of Health to come up with data that can inform policy and intervention. So as a result, we embark on a nationwide study that looks at the prevalence of psychoactive substance, looking at the risk factors and the association of these psychoactive substance and mental health conditions. So we did in each of the regional headquarters a community-based survey. So as part of that survey, we noticed that Kush is mostly is one of the most commonly illicit drugs that has been abused in Sierra Leone. But for psychoactive substance, tobacco is the most frequently used psychoactive substance, second to alcohol, and then Kush. About 62% of the respondents are using illicit drugs, which is very serious. 62% of people aged 18 years and above are using psychoactive substances. And from 2015 to 2024, we noticed that there is a huge increase in psychoactive substance, over 1,000% increment of psychoactive substance use. And 64% of the respondents reported accessing psychoactive substance from the neighbors, the neighborhood, and then also 42% from ghettos, 10% from family members, 43% from friends. The source of this psychoactive substance, and also 45% of the respondents reported using psychoactive substance due to peer pressure, and 32% say they use these psychoactive substance because of stress. They want to reduce the stress. And 27% of the respondents reported experiencing withdrawal symptoms from this psychoactive substance. And then about 8.3% have been arrested for unusual behavior, and 70% have neglected their families, and 12% have lost their job, and 12% are engaged in illegal activities, and 9.4% are involved in treatment program. It means these are people that have visited either a mental health unit in the district or the psychiatric hospital in Freetown, about 9.4%. And 63% of psychoactive substance users reported experiencing stigma. Stigma is a major challenge in this part of the, and I know, in fact, globally, it's a challenge in terms of stigma, and stigma sometimes prevents people from seeking help, or delay in referral that makes the situation very complex to for addicts. So as you can see from the study we did, about 63% reported experiencing stigma due to the addiction. And then with age, we saw that the youth are more associated with psychoactive substance use between the ages of 18 to 34 years. They are more associated with psychoactive substance use, and male, about more males are abusing psychoactive substances. And the other interesting finding is that we were able to reveal that marriage, people who are married are more prone to psychoactive substance use. Then 1.9%, about 2% of the respondents reported knowing a psychoactive substance user who completed suicide. About 2% of them commit suicide, and about 0.5% have attempted committing suicide. So something that is very serious, and then about 11% of the respondents reported having general anxiety disorder. About 11% of them, and then for depression, about 75% of the respondents had various levels of depression, starting from mild to severe form of depression. So the findings are very alarming. For example, tramadol, tobacco products, marijuana, kush, and alcohol exhibit the highest level of severe depression in people that use psychoactive substance use. In conclusion, basically, there is high level of prevalence of psychoactive substance use in Sierra Leone, and then males are significantly affected. There is a strong association between psychoactive substance use and depression. So, and this is the first study, I think, in the sub-region, second to after Nigeria, to do a nationwide epidemiological study on psychoactive substance use. Thank you so much.
Thank you so much. That's really interesting findings and work that we need to have to contribute to the evidence base that comes and originates from Africa. I'm wondering if you could maybe just, Dr. Jalloh, comment on the fact that there were quite high prevalence rates of the specific psychosocial determinants that influence this. So, you know, we're looking at, you said they were homeless, that they didn't have contact with their families. There obviously seemed to be relational challenges and those kind of psychosocial determinants. Was there any recommendations in that context that the study sort of could advocate for?
Yes, we prefer so many recommendations, starting from the government to partners and the community. So, for example, for the government, we recommended that there should be a national policy on on psychoactive substance use, especially on prevention aspect and treatment, and then rehabilitation, and also to collaborate with community leaders to raise awareness. Then empowering people with psychoactive substance use issues. So for the partners, of course, they need to work closely with the government for us to improve access to drug addiction treatment, and then also on laws and policies, because that is a major challenge also we have in Africa, in terms of policies and laws to address these issues. It's challenging. For example, in Sierra Leone, we know the act that we have is 2008 Narcotic Act, which has so many loopholes that needs to be amended. And we have the alcohol policy, but the implementation aspect is a huge challenge. So for the social social determinants you mentioned, basically, we recommended that we need to organize workshops and seminars in schools, because the age of those that are using psychoactive substance are mostly the youth, and most of them are school-going people. So or university students. So we need to organize seminars to raise awareness about the risk associated with psychoactive substance use, and also to create support groups for those that are facing substance use challenges, so that they can share their experiences and coping strategies in a safe environment. And finally, to form community groups that can advocate for stricter regulations of psychoactive substance, increase funding for local health services. Yeah, thank you.
I mean, thank you very much. And I think I just wanted to highlight that recommendation-wise, because we often talk in substance use services about the interventions related to the substance and the harm reduction and the withdrawal. But obviously, it's a fine interplay between also community support structures, psychoeducation, and addressing those social determinants that kind of influence it. I want to just divert a little to Dr. Jegede again, because those were important stats that you presented. And he had some research similarly from Nigeria. I wonder, Dr. Oluwole, if you want to go ahead with that.
Yes, thank you, Dr. Lackman. So recently, some of my colleagues here at Yale collaborated with colleagues in northern Nigeria, Kaduna State. And so the big thing is, when we got the data, I sent the data back because I didn't believe it. Like, how is it possible that these are true numbers? Like, there's no way I'm going to publish this data and they're going to ask me, this cannot be true. Almost 15% of young people 18 and over were using IV drugs. Sedatives, cocaine was like 40%. Like, how is it possible? I could not believe those numbers. I left Nigeria 2 decades ago, but I'm like, this is not possible. So I really applaud what you're doing, Dr. Jalloh. This is a big problem, emerging concern in Africa. And I was going to ask you really, how can the diaspora help? I have 3 board certifications in addiction, and I'm here. And I have colleagues who also are Africans living in America and in the UK. I know they're Europe, South Africa, and other places. How can we help West Africa? What are your thoughts?
Yeah. Before coming to your answer, I think back to the psychosocial determinant. During the announcement of these drugs and substance use as an emergency, we have like 5 pillars. We were in one of the pillars is reintegration and social support. These 2 pillars are led by the Ministry of Social Welfare, because most of these guys that abuse these substances are not in their homes no more. They sleep and live in ghettos, under the bridges. They are somehow homeless per se. So the role of the social welfare ministry is to integrate these people back into their communities. So that is how we are tackling the issue of social determinant. Back to your question, we are open to partnership, to collaboration with anybody, whosoever thinks that he or she can come in and help us. As I mentioned earlier, in Sierra Leone, we are in their need of especially addiction professionals and mental health professionals. You are welcome, Doc. And I think what currently is going on there is a Pan-African and a UK a network that is being established by some psychiatrists in the UK under the Rural College of Psychiatrists. So I think I will link you up to the admins to see how they can incorporate you into that platform. But we need you. And you're highly welcome, because as I mentioned, there is a huge gap in terms of human resource. Thank you.
There are lots of good questions coming in the chat. And so we're going to try to, as much as we can limit our responses, but try to get to all the questions would be fantastic. I think a couple of good ones is, and I'm not remembering all the numbers, so I'm going to rely on you, Dr. Jalloh and Dr. Jegede, because in the US, I think the opioid epidemic obviously was huge, but would you still say that that is the #1 substance use affecting Americans? And I guess if the same question could go to you, Dr. Jalloh, like what is the #1 substance? And maybe it's different and obviously in every country. But the question is really related to opioids in general, and is how is big pharma contributing to that? And there was a huge lawsuit in the US about, what happened with oxycodone and other pain medicines in the US, but I don't know how that relates to Africa. So I'll let you kind of both take it from those standpoints about how do you think about pain medication, then people using having opioid use disorder, the correlation or maybe lack thereof of a correlation, but really also highlighting what is a primary substance being used, because sometimes it gets overshadowed of other substances people are using that may be more common and just as lethal, such as alcohol. So I'll let you both sort of take it from there.
So that's a big question, Dr. Durham. But yes, by far it is opioids in the United States. But it's a little more than that. Now we're in the 4th wave of the opioid epidemic. We don't have time to go through all the phases. But in the 4th wave of the opioid epidemic, it's now a combination mostly of stimulants, that is cocaine, methamphetamine, and highly potent synthetic opioids like fentanyl and carfentanil, which is thousands of times more potent than morphine. This is what people are using now. But in addition to that, we're now having xylazine. We're seeing wounds that don't heal anymore. People are having festering limb wounds, all over their body, you know, like anesthetic wounds that don't respond to regular wound treatments, you know, xylazine, K2, and other synthetic opioids as well. So the problem we're having right now is really a mismatch, all just put together. Opioids, particularly of opioids and stimulants. Those are the big ones now.
Yes, I think it's similar to what Dr. Oluwole mentioned. Opioid is on the rise in Africa, and for Sierra Leone, as I mentioned earlier, there's this primary substance of abuse called kush, which is a concoction or mixture of different psychoactive substances, including tramadol, opioid, fentanyl, and then marijuana, sometimes cocaine, even sometimes diazepam, sometimes amitriptyline. It's just a concoction of different psychoactive substances, and it's very fatal sometimes. That relate to overdose and death. Yeah, it's similar. It's similar. It's increasing every year. It's increasing for Sierra Leone. From 2015 to date, it has increased exponentially, drastically. Yeah.
If I could add to that real quick, we've had over 100,000 deaths since 2020 in the United States. 75% of those deaths are related to opioids. That's a huge number. Those are the numbers we were seeing globally before the COVID pandemic. Now it's 100,000. In fact, I did a review in 2022, and I wrote, one of my comments was, no, we don't have the numbers yet. And an insider told me, this is even more. We're having way more than 100,000 now, and this is still the situation. We're in a very uncharted waters now. And to add to that, there's a racial disparity now in the deaths. The deaths we're seeing now, it's amongst African Americans and Native Americans. It never used to be like that. Now, one of the reasons I alluded to is because people who were not tolerant to opioids are taking, they don't know they're taking opioids, so they don't have tolerance to it. And they're taking opioids that are 10,000 times more potent. Unfortunately, we also have disparities in naloxone distribution, naloxone education, all of that put together really fueling the disparity amongst African American and Native American communities.
I want to just come in there because I think I was going to mention another question that was asked here, but just to add on to what you've said, Dr. Oluwole, Juliet Naku has had an interesting thought here around the role of Big Pharma in fueling the opioid use in Africa, particularly, and amongst other low-income countries. And she questions, is there perhaps an aggressive marketing promotion specifically around pain management? And I've heard a few kind of talks around that where, previously, opioid naive almost using for these conditions. And I wonder if there hasn't been a little bit more of that aggressive push to use for that from Big Pharma, and kind of relating to what you've just said about how they're disproportionately affecting particularly vulnerable groups that haven't been used to using these kind of drugs. But I actually want to focus on another question that's come up in our Q&A, and that's from Dr. Mafuzi. And he says, interestingly, like you've mentioned, seeing that over 60% of young people from most of the studies are increasingly using psychoactive substances, he's asking, is there something common you see in terms of, particularly in Africa, where people use herbal or alternative forms of medication to treat underlying ailments that can be physical or mental health? And how do you approach that, especially when these patients come for assistance in terms of microdosing for some of these psychoactive substances? I thought that's an interesting question. If Dr. Jalloh, if you wanted to maybe take that.
Yes, we see a lot of those cases, especially those that are working in road constructions, those that are working for big manufacturing companies. They use this opioid for pain relief. So along the line, they become addicted to this especially tramadol, because morphine is difficult to get, but tramadol is very common. But what we noticed is that the dosage of the opioid, the tramadol, is very high. We have seen 800 milligram of tramadol, 400 milligram of tramadol. And these substances, these medications are not produced in Sierra Leone, but they are brought in or imported from other parts of Africa into Sierra Leone. So these people are using these psychoactive substances maybe to treat an ailment, and along the line, they become addicted to these psychoactive substances. Yeah.
Thank you
Yeah.
so much. I do want to end. I'm going to try to squeeze in this last little, because I think it sort of wraps up a lot of what we're talking about today. There's obviously grave difficulty with doing substance use treatment, and whether it's the workforce, not enough people, or whether that's the resources that you need, all of the other things to help people with their social determinants of health. But there was a question in the chat just about thinking if substance use, and someone from Sierra Leone also commented, Dr. Jalloh, about two people are essentially asking, is it in policy, right, in the country to think about substance use as part of mental health? And how do you create programming, right, if a country or an establishment does not recognize that this may be a problem? You did mention that there was a public health initiative about being a public health problem, but how do you address it as someone called it like a national drug master plan, or how do you work on these things from a policy level if it's not incorporated into everyday people's thinking that it's just as important as mental health? Dr. Jegede,
Yes.
I'll start with you to think about how that looks in the US, but Dr. Jalloh as well, and then we'll wrap up. So maybe 30 seconds each. Dr. Oluwole?
Oh, yeah. So we're talking about how can you give me the question again real quick?
So thinking about in policy, if you don't have a plan, right? If
Yeah.
you don't put it in policy that we need more infrastructure for substance use, we need to recognize it as an issue, that then it's hard then, right, for programs, states, countries to actually do work around this.
Interestingly, we have that problem here in the US as well, that challenge, which is also part of my work, which is co-locating and integrating substance use disorder treatment into mental health treatment. That has been a challenge. The state level here in the state of Connecticut is part of what we're doing. We need to co-locate, we need to integrate substance use disorder treatment into mental health. It's part of mental health, it's part of health. We need to do that at every level.
Dr. Jalloh?
Yes, I think it's similar. The only difference is that we are using the multi-sectoral approach. We're using many different ministries, departments, and agencies to integrate addiction into their programs and specific disease programs. So we are using a multi-sectorial approach to address this issue of psychoactive substance use. And also we are integrating mental health and addiction into disease-specific programs, especially in the Ministry of Health. For example, HIV, hepatitis, TB. Yes.
Mm-hmm.
Thank you.
Fantastic. Thanks for everyone for staying this whole time with us and asking some fantastic questions. Sorry we couldn't get to everyone. It sounds like we probably need to have a follow-up webinar taking an even deeper dive into substance use. It affects many people, as we've heard today from both Dr. Jalloh and Jegede. And there is a huge public health crisis, it sounds like, in both aspects of the world, right, that we need to address from many different perspectives. So we have a survey. Please fill it out, an evaluation of how we did today, what future topics you may want to hear from us. and anything else that you think would be helpful as we continue to do these webinar series and for AGMHI. Thank you, Dr. Lashman, for co-facilitating with me, and Dr. Jalloh and Jegede for your time today. We really appreciate it.
Thanks, everybody.
Thank you so much for this opportunity.
Thank you.